Good morning, good afternoon, and good evening, depending on which part of the world you are in. Today, I have the distinct honor and privilege to introduce Professor Paul Ko, who is currently the Director of Hepatology and Professor of Medicine at the Stanford University School of Medicine. He received his bachelor's degree in chemistry at the Oberlin College, his medical degree from the Wayne State University School of Medicine, and his internal medicine training at the University of Maryland, and his gastroenterology and hepatology training at the Mayo Clinic Rochester. Dr. Ko was professor of medicine at the Indiana University and the medical director of liver transplantation, where he distinguished himself in the field of viral hepatitis and served as the principal investigator for multiple seminal trials that established the efficacy of direct-acting antiviral agents for the treatment of both non-transplant and post-transplant hepatitis C infection. His clinical and research interests are in novel therapeutic approaches to treat viral hepatitis, including hepatitis B and C elimination and other chronic liver diseases. Dr. Ko has published over 200 original articles in journals, including New England Journal of Medicine, Lancet, American Journal of Gastroenterology, Hepatology, you name it, all the major journals in the field of gastrology and hepatology. He is currently an associate editor for clinical and molecular hepatology and has served on the editorial boards for multiple journals, including Hepatology, Hepatology Communications, and the Journal of Clinical Gastroenterology. He has served on numerous societal commitments for the American Association of Liver Disease, ACG, and AGA. He is the recipient of multiple awards for his clinical care and teaching at the Indiana University and the Stanford, including the Outstanding Young Clinician Award, Distinguished Teacher Award, and the Trusted Teaching Award at the Indiana University, and most recently received the Stanford University Department of Medicine Master Teaching Award. With that introduction, I would like to welcome Professor Paul Ko, who is going to talk on viral hepatitis C, the pathways elimination. Dr. Ko, over to you, and please share your screen at this point.
Thank you so much, and I appreciate the kind introduction, and good morning, good afternoon, and good evening. So we're going to talk about the hepatitis C in the post-DAA era, some of the challenges, innovations, and what is a potential path toward elimination, which I think we have over the past decade now defined, and hopefully with momentum, this is a disease that we can talk about mainly in the past tense. Disclosures. So we'll just talk about a patient that we would see in the U.S. And this is would be currently a fairly typical presentation. This is a 32-year-old male with a history of injection drug use presents to your clinic. They have abnormal liver chemistries and a positive hepatitis C antibody. Recently discharged from the hospital where they presented to the emergency department after an overdose. Now is on opiate substitution therapy, buprenorphine, and currently living with his parents. Like so many of these individuals, they're young. Their exam is actually completely normal, and their blood work is actually near normal, other than a mildly elevated ALT that comes back. And again, the anti-ACD antibody is positive. So what are the next steps in someone such as this? So looking at the magnitude of the disease, this is from the WHO, looking at the prevalence of hepatitis C by region and worldwide, likely 50 million individuals are infected with hepatitis C currently. And you can see here the Americas are here in the left, and European in the middle, and then Western Pacific region in the right side of the slide. But you can see that the largest burden is actually not in the US, but rather it's in Europe and the Western parts and Southeast Asian parts of the world. But this is a worldwide challenge that we're going to need to address. Looking in the US, you can see here that the number of acute cases of hepatitis C has actually leveled off some within the past few years. It had been growing since 2016, and you can see now that hepatitis C cases have leveled off. Part of this is due to public health measures. Of course, there was a bump you can see here, particularly the COVID pandemic clearly affected our ability to control this disease. But you can see here that there's just been now a leveling off, and only time will tell if we can maintain this momentum. within the United States and then worldwide, you can see there's always variability in the number where hepatitis C cases occur. In the U.S., you can see here that we have several hot pockets of hepatitis C infection, particularly in the Midwest here, but of course also New York and New England has high rates of acute hepatitis C. And again, New York in particular, the state of New York, has really done a remarkable job of investing in measures to control hepatitis C and link to care. This is a disease that is transitioned. This looks at just the reported cases of acute hepatitis C by age group. So in light blue is the youngest, and in red here is the oldest groups. And when I started and became interested in treating hepatitis C in the 90s, the dominant disease then were people who were born between 1945 and 1965. Now this group is actually still has a reasonable prevalence of acute hepatitis C, but not nearly as high as those ages 20 to 39 and 40 to 49, where the highest rates of acute hepatitis C occur. And this is also true worldwide. And this is because of injection drug use. And it's this group that we're going to need to intervene on to be able to control hepatitis C. This is, again, another report just showing that the epidemiology of acute hepatitis C or chronic hepatitis C cases is actually bimodal. So in the back in the mid-2000s, we talked about the birth cohort. So there was a group of people born between 1945 and 1965, and if we screened this group, we actually would be able to find about 2/3 of people who are infected with the hepatitis C virus. Nowadays, you can see here this 20 to 50 group here is probably the largest group, and then followed by the group that was here, ages are born between 1945 and 1965 over here on the right. And again, always noting that men roughly 2 to 1 have a higher prevalence of newly reported chronic hepatitis C cases. So what does all this mean? Long-term sequela. Hepatitis C worldwide used to be the leading indication for transplant for hepatitis C. It's actually quite rare now, except for cases of hepatocellular carcinoma. But what you can see here is that hepatitis C cases, which are shown in this hash mark here, have declined. And you can see here they've actually declined quite dramatically through 2018. You can see here that the number of cases have really fallen, and this is the pre-DAA era and the DAA era. And you can see here that we've really done a remarkable job of reducing the long-term that chronic viral malaria declining, tuberculosis declining. So we clearly have to intervene. And remember, this is both hepatitis B and C, and we have an effective disease or vaccine for hepatitis B. We still need other intervention measures. And again, as I've been saying, because hepatitis C is so tightly linked to the opiate epidemic here, the prevalence of hepatitis C in the PWID population or persons who inject drugs is shown here. And you can see here, we won't get control of hepatitis C until we intervene effectively to reduce injection drug use across the world here. And I just show you in various parts of the world the various prevalences as it relates to hepatitis C and injection drug use. And this is the most important risk factor for hepatitis C infection. And you can see here, those who inject drugs have a propensity to share needles. It's usually acquired often just after individuals begin injecting. Hepatitis C, unfortunately, can survive on cookers and cotton filters for days and even longer in a needle barrel. And it's much more infectious than HIV, tenfold more infectious. And it's also prevalent in those who have a history of injection drug use, 60 to 80% of individuals. And in the US, it's about 2/3 of individuals who inject drugs are chronically infected, and they make up anywhere from 60% up to 85% of all new cases of hepatitis C in the US. And really, this experience is not different worldwide. Another important group that we have to address are those who are women of childbearing age. This is, again, just showing the bimodal peak that I showed you, but younger individuals are getting infected now with hepatitis C, and this is changing the prevalence of hepatitis C among pregnant women. It's still a relatively low rate here, but you can see here from 2000, the prevalence of hepatitis C in pregnant women, 0.05%, in 2019, 0.49%, and particularly if you look at co-infected individuals, which we often see worldwide, you can see here the risk has doubled now to 10.8% in HIV-positive women. So clearly an area here that we need active intervention, and we're going to discuss this a little bit later this morning or this afternoon. COVID worldwide disrupted hepatitis C treatment and elimination efforts. So just you can see here, and I'm using US data here, but regarding the effect on COVID, you can see here that there was a marked increase in drug overdose deaths between December 19 and December 2020. And you can see here there was a markedly substantial reduction in hepatitis C screening and testing reported by local health departments, as well as decreased hepatitis C treatments as we changed our efforts to address the pandemic. And fortunately now we're rebounding from this. And I also wanted to introduce to you an important concept in hepatitis C elimination, which is treatment as prevention. As you will see here in this modeling study here, if left untreated, one active injector who can potentially infect up to 20 others with hepatitis C within the first 3 years of diagnosis. I'll also show you some modeling studies that show that really the way to approach hepatitis C is to treat immediately. This includes all people diagnosed with chronic hepatitis C, as well as those who are recently seen for acute infection. So with our DAA therapies, which became so effective, there was a call in 2016 to eliminate hepatitis C. Actually, it was to eliminate viral hepatitis. This WHO vision was to eliminate viral hepatitis as a major public global threat by 2030. And what did this mean? This meant by 2030, 90% of individuals worldwide diagnosed, 80% treated, 2/3, 65% reduced mortality. And this was not the only organization to make these recommendations. The United States had a hepatitis B, hepatitis C elimination strategy, which was very similar. But of course, as we've now emphasized, you will not achieve any of these benchmarks without engaging in treating those who inject drugs. And again, this is a substantial portion of the infected individuals with hepatitis C, and most importantly, for new infections, this is the dominant risk factor. Happily, a few years ago, Harvey Alter, Michael Houghton, and Charles Rice were all awarded the Nobel Prize for their efforts, which were seminal in contributing to our understanding of hepatitis C infection, and certainly well-deserved. So just, again, I want to make sure everyone understands what hepatitis C elimination means. It doesn't mean you're going to get rid of the virus. So epidemiologically, we have eradication and we have elimination. So eradication means that there is a permanent reduction to 0 worldwide incidence, and intervention measures are no longer required. That's never going to happen with hepatitis C. But an example of this would be smallpox, which has been eradicated. Elimination means reduction to zero incidence of an infection in a certain geographical area, but intervention measures are required. So an example of this is polio. There's a small recurrence now, but polio has been effectively eliminated. And I just want to point out that most infections that have been eradicated or eliminated have been as a result of effective vaccines. There are exceptions, though. So one is onchocerciasis, or that causes river blindness. And there have been, this is a disease that's been eliminated. Over 100 million individuals have been treated, mainly with ivermectin. I might add that those who came up with this treatment also won a Nobel Prize. So you can certainly eliminate a disease without an effective vaccine. It's been done before. I just again like to point out that we do have an effective vaccine for hepatitis B, but we've not been able to eliminate hepatitis B. And again, what are some of the challenges with this? A big one is underdiagnosis. This is the largest gap in the cascade of care. So if you look at our pool of hepatitis C, maybe half are diagnosed and aware. Lower amounts have HCV RNA confirmed. Lower amounts have disease staging, and you can see here the cascade continues to decline. Again, various areas of the country. I just want to give a shout out to New York. They've done really a remarkable job of reducing this cascade care gap. But this is something worldwide we're going to have to address. And as we treat more individuals, it's important that we have point of care testing, because in addition to a decline in HCV prevalence, there's also a reduction in hepatitis C RNA positive individuals in those who are anti-HCV positive. So you can see here that I have here, and this is from the US NHANES data here from 2003 to 2010, estimates of the number of individuals here who are anti-HCV positive, over 4.5 million in 2003 to 2010. It's down to 2.7 million here. But if you can see here, just 73% were viremic, and by 2016, 57% of individuals were viremic. So you can see here that this will be a challenge for us. And fortunately, we have some point of care tests that really help, although there are other strategies that we can discuss. This is just New York State, just because of this wonderful invitation. But you can see here that the rate of hepatitis C by diagnoses have really fallen since 2023. This really shows that aggressive intervention measures can reduce the prevalence of acute hepatitis C. And so our intervention measures clearly do show some efficacy here that's substantial. So how are we going to be able to address this? Well, an important aspect is screening, and a variety of organizations in the U.S., the USPS task force, that's the United States Preventative Services Task Force, actually recommended screening for hepatitis C in those ages 18 to 79, and this is a one-time screen. And this was given an evidence grade of B, which means there are substantial opportunities to impact hepatitis C. Centers for Disease Control also came out with a similar recommendation, a one-time screen for those greater than 18 years of age, except where the HCV positivity rate is less than 0.1%. Also screening for pregnancy, those who have risk factors, and periodic screening, of course, for those who are at risk, such as injection drug users. I would say that with any disease in elimination, universal screening is really the way that we will get at successfully finding these individuals and linking the care. We have tried in many, many diseases risk-based screening, and really for something as broadly prevalent as hepatitis C, universal screening worldwide is going to be the strategy. Happily, also, access to direct-acting antiviral agents has increased. There's still gaps, but if you can get access to hepatitis C, curing turns out to be quite straightforward. It's actually curing the population, which is challenging. I show you here some of the DAAs. These are the ones available in the U.S. here. And again, the important thing is here we have pan-genotypic therapies. We have generic therapies worldwide. Also here, soft declatosphere, they can be given for anywhere from 8 to 12 to 24 weeks, depending on the DAAs and the sustained response rates. The important thing is twofold. Number one, cure rates greater than 95%. Number two, we have many pan-genotypic options. In the US, we have glucapavir, prevenosphere, and sofosbuvir, velpatasvir. Worldwide, you also have sofosbuvir, declatosphere as well. And this is the recommended regimens, again, in the US for most persons with hepatitis C. And this is sofbel and glucapavir, prevenosphere. Worldwide, so sofosbuvir, declatosphere is also an important DAA regimen. And again, these work in those who are compensated liver disease. Soft velpatasvir, soft ledipasvir, and soft declatosphere can be given in those who are decompensated. And with all of these DAAs, the drug-drug interactions are actually pretty darn minimal. And again, there are a few that you have to work around and adjust, but you can find a DAA regimen essentially for anyone who is chronically infected with hepatitis C. And the drug interactions are also pretty darn minimal, particularly sofosbuvir-based therapies with HIV. These are very easy to administer. This is also true for sofosbuvir, declatosphere as well. And again, in those who have substance use disorders, there are essentially no substantial drug-drug interactions, which was a theoretical concern for many years, but it is no longer the case here, as you can see. And I list here medicines used to treat not only opioid use disorders, but also alcohol use disorders. There are very few, if any, drug interactions that are meaningful. Treatment is very easy. This is the AASLD simplified regimen. There are many of these that are published. You essentially can treat the vast majority of individuals who present now with hepatitis C. And these are those with chronic hepatitis C who don't have cirrhosis and not previously treated. You do need a few basic blood tests, CBC, INR, viral load, should test for hepatitis B and HIV, do your drug interactions, and you can treat these individuals with pan-genotypic therapy. This also includes hepatitis C. You can even use a simplified regimen for hepatitis C in those with cirrhosis. The AASLD recommends looking for resistant-associated substitutions. However, many places, including our own institution, have evolved, and we typically are not checking RASs, rather treating first and then retreating with soft Velvox, the salvage therapy, if they don't achieve sustained response. You do need to stage fibrosis. There are lots of different ways to do this. We used to use a liver biopsy. That's essentially not done anymore. We rely either on elastography or serum biomarkers, and you can actually use some of the non-invasive assessments of liver disease or NILDAs here. AST, platelet ratio index, and FIB4 they have very good negative predictive value. And either one of these, if the FIB4 is less than 1.45 or the APRI is less than 0.5, you've ruled out cirrhosis. In so many of our young individuals, this is actually the case, and these individuals can have their fibrosis readily assessed. The imaging studies, if you have one, can also diagnose cirrhosis if required. Again, in many resource-constrained areas, you're not going to get that much in the way of imaging, but often an ultrasound is available. So our individual returns, viral load 120,000, genotype 3A, FIB4.56, what are our next steps? So we treat this person with pan-genotypic therapy, and in the US, this person could have received sofosbuvir, velpatasvir, or glucapavir, prevenosphere. Again, SVR is to be expected. So what do? So you treat, don't really need to monitor. You can confirm SVR. So if you have hepatitis C, we verify in follow-up, SVR12, that these individuals have a normal ALT. And again, we're looking for MASLD or alcohol-associated liver disease. If the ALT does not normalize, they still need to remain under your care. But if ALT normalizes, then these individuals can be dismissed from care. If they have risk factors for hepatitis C infection, such as ongoing injection drug use, you need to periodically survey these individuals. If they have cirrhosis, then they should be screened for hepatocellular carcinoma. And again, either if you have cirrhosis, either a baseline endoscopy to screen for varices or assess and treat compensated advanced chronic liver disease if you have portal hypertension with carvedilol or a non-selective beta blocker. All the special populations that I devoted my career to can now be treated this way. And as you can see here, the cure rates, all of them, including transplant, dialysis, acute hepatitis C, all of these, you get very, very high SVR rates that aren't different than our regular population. This includes now children as well, down to the age of 2. If you have decompensated cirrhosis, the SVR rates aren't quite as high, but they're still quite good, 85% or higher. We add ribavirin, and again, worldwide, declatosphere, sofosbuvir should be added here as well, up to 24 weeks. And again, with ribavirin, again, you can't treat everybody, but you can really get close to these individuals, treating most people with decompensated liver disease. What about pregnancy? Actually, there was a recent paper looking at ledipasvir, sofosbuvir in pregnant women. SVR rate was 100%, and the PK during pregnancy was unchanged, and happily also no infant developed HCV infection, and a larger study is ongoing now with sofosbuvir and velpatasvir. If you have transplant in your part of the world, we often treat these individuals. If the MELD score is less than 20, you have a better opportunity to recompensate. If it's higher than that, or if you have severe portal hypertension, orthotopic liver transplant may be a better choice as well. And happily, we're seeing fewer and fewer of these individuals, but with severe portal hypertension, SVR is unlikely you're going to recompensate. There was, for a period of time, a concern that DAA therapy would change the natural history of hepatocellular carcinoma. There have now been subsequently multiple well-controlled studies in larger cohorts that have shown that actually treating hepatitis C in this setting of hepatocellular carcinoma is actually leads to a benefit on the survival, and so is associated with lower mortality. Obviously, if you diagnose somebody with hepatocellular carcinoma, you need to treat the HCC first, but you can get these people on DAA therapy. SVR rates are a little bit lower, but certainly patients are going to benefit. And just about this concern, what we learned about this was that if you have somebody with hepatocellular carcinoma who has a nodule, make sure all the indeterminate nodules are characterized prior to treatment. This was a study that came from Italy that showed that if you initiated DAA therapy in those with undefined non-malignant nodules or had ascites or AFP, that you were at risk for HCC. So before we embark on this, we make sure we know what all the nodules are on axial imaging. Acute hepatitis C, you just treat. We used to follow these individuals, no longer the case. And again, this is treatment as prevention. This was a microsimulation model that was published 7 years ago, which showed that treating hepatitis C acutely is actually cost savings when you simulate the lifetime of somebody with hepatitis C and the risk of transmission. So treat all acute hepatitis C at the time of diagnosis. Worldwide, to eliminate hepatitis C, we're going to need to decentralize our care. So how hepatitis C for decades was treated centrally. That is, people would travel great distances to see specialized specialists who knew how to care for those with hepatitis C. Nowadays, we are taking hepatitis C treatment to the areas where they're encountering healthcare providers. So this means treatment of those who have opioid addiction at addiction treatment centers. We want to treat hepatitis C. We want to test these individuals, link to care immediately, educate about the psychological or importance of treatment, treat and invest in harm reduction services, and if necessary, directly observe therapies. And there are many success stories worldwide. I'm going to just share a few of these individuals. Again, centralized care used to be the model. We're now decentralized, and hepatitis C is treated at sexual health centers, community health centers. We are investing in treating in the prisons, and worldwide, this is a strategy that is going to allow us to eliminate hepatitis C. Here, I just list some of the components of the hepatitis C elimination programs here. And you can see here that you need data for planning and monitoring program performance. You need a plan of action with limited numerical targets. You're going to need support from your civic or political partners. And I'll show you some of the various interventions we've tried in the US. You need a model to finance this, and this means engaging hepatitis C drug manufacturers as well as those who run the diagnostics. And obviously, we want an operational research program as well. Perhaps the most successful elimination program to date is the program to eliminate hepatitis C in Egypt. This was a undertaking of really substantial proportions where they screened 49 million individuals, 4.61% were positive. And you can see here, that you had here 1.5 million individuals, were tested for hepatitis C. They managed to diagnose 350,000 individuals, or 350,000 were, negative, and 1.1 million were positive. And you can see here that they ultimately led to curing 381,000 individuals who had a sustained response. Just 1% had treatment failure. And hepatitis C is likely going to be the first of the amongst the first companies or countries to eliminate hepatitis C. So going back to our case now, our individual initiates therapy for hepatitis C, but then returns and says that he's lost his medicines and missed 4 days of therapy. What are the next steps? Variable adherence, particularly those who have unstable housing or other risk factors, is often a challenge. And we do have some data here showing that you can actually predict SVR even with variable adherence. And if you're greater than 90% adherent, your SVR rate is not compromised. Less than 90% for soft valpattocin, the SVR rate is still pretty good, 91%. That's still high. With glecaprevir preventaspir, again, 8-week regimen. If you have less than 90% adherence, 100% SVR, greater than 90% adherence, still have high SVR rates. The AASLD IDSA guidance here shows that if you miss treatment less than 7 days in the first 28 days, your SVR rate is likely not affected. If you miss greater than 8 days, then you need to restart DAA therapy, but look and see if the HCV RNA is positive and extend treatment for an additional 4 weeks. If you miss days after the first 28 days, if it's less than 7 days, you're fine. If it's 8 to 20 consecutive days, you can see here that if you have detectable HCV RNA, that you should stop and treat as a non-responder. And that's also true if you miss more than 21 days as well. But you can get all of these individuals to SVR if you manage to get them the adequate duration of DAA therapy. Reinfection does occur. The reinfection rate in this particular study was 2.65 per 100 person years, but you can retreat these individuals. And historically, we've always, by the way, retreated diseases. We retreat hepatitis C. People can get syphilis a second time. People can get gonorrhea a second time. So certainly there's no limitation in the number of times we can treat these individuals. Obviously, harm reduction measures are going to be important, and as are education and then screening. And again, those individuals who are who inject drugs, they need to have periodic screening at least annually for hepatitis C. To eliminate also, we should re-energize vaccine research. This was published in the New England Journal. This was a randomized trial of a recombinant vaccine to prevent chronic hepatitis C. This did not achieve its endpoint. It did not prevent chronic infection, but this is an area that I think would, in a substantial way, impact our ability to eliminate the disease if we have a hepatitis C vaccine. We don't have this yet. Our individual does come back and completes 12 weeks of sofosbuvir velpatasvir. You see him back in a year, and he has stopped buprenorphine, but unfortunately relapsed and was injecting fentanyl. He now has elevated liver tests, and the question is, what do we do? In this individual, you'll need to check the genotype. Almost the vast majority of these will be reinfections, not relapses. And then again, if it's a new genotype, you just treat the virus. If it is the same genotype, we don't usually sequence the virus, but there are late relapses. They're extraordinarily uncommon. Worldwide, our strategy, or in the US, we use sofosbuvir, velpatasvir, and voxilatravir. You can also use glecaprevir, preventaspir as well, but it is an alternative. And for glecaprevir or preventaspir, you can either add ribavirin with sofosbuvir if you fail glecaprevir or preventaspir, or you can use sofosbuvir, velpatasvir, and voxilatravir again for 12 weeks. The salvage therapy Sofl-Vox is very effective, 96%. Our individual who relapsed, we retreated with Sofl-Vox and re-engaged in harm reduction. We did have, a couple of years ago, a national hepatitis C elimination program in the United States. Unfortunately, this is unlikely to move forward, but this was going to be a substantial investment to eliminate hepatitis C, and the cost savings were going to be, as you can see here, substantial. The federal elimination plan included point-of-care testing, broad access to DAAs, and empowering healthcare delivery. Importantly, test and treat models of care are going to be important. They're done. This was how we were able, how the Egyptians were able to eliminate hepatitis C in their seminal effort. We now have in the U.S. A point-of-care HCV RNA therapy. This is used in Europe and Australia, and now in the U.S. This is a finger stick. No venipuncture is required. Runtime 60 minutes, and its HCV RNA detection limits are quite acceptable. You still need some kind of point-of-care testing for hepatitis B, as well as a disease staging, and you have to account for the assay runtime. But this is point-of-care testing is something that should hopefully allow us to link, make immediate diagnoses and link to care. Previously, others had advocated, although I don't believe this is practiced commonly, that if you have a point-of-care antibody, the DAA therapies, people have considered treating just antibody positive, but the number of individuals now who are viremic has declined substantially, and we really do need HCV RNA levels to be determined. Australia has a Netflix model, a subscription model that has worked very, very well for hepatitis C. And when this was introduced, there was marked HCV treatment uptake. And you can see here by 2016 over here on the right, that with a government funded program, that they had a dramatic increase, 75,000 individuals who were treated, which was 40% of the HCV population. In the US, just 2 weeks ago, one of our senators, or two of our senators, introduced hepatitis C legislation. This is based on a successful pilot program in Louisiana. As it turns out, Senator Cassidy, one of our legislators, is a hepatologist. And so this was the Cure Hepatitis C Act, which they wanted to implement nationally. It's a 5-year subscription model that allows the federal government to procure hepatitis C drugs through competitive bidding process, and deploy this throughout the country and in prisons as well. Hepatitis C really, as with so many other diseases, requires a syndemic approach. This is what the state of New York has deployed. Syndemic just means that you employ interventions that apply to many different diseases. So this would include, for instance, hepatitis C and injection drug use as an example. And the populations here you can see are persons who inject drugs, involved in the justice system, baby boomers, homeless, and HIV individuals. And obviously their priority settings are listed here. In the U.S. correctional facilities, harm reduction programs, drug and substance use treatment programs, and those programs that serve the homeless. And just, again, a shout out to those in New York. You can see the cumulative percent of persons diagnosed with hepatitis C who cleared infection. has increased substantially. You can see the data in orange is 2023 up to 54% of individuals. In New York City and New York State, 55%. And so this is really quite impressive. You can see here that these intervention measures are actually working. So this is CDC data through 2023. And you can see here that the incidence rates of new hepatitis C cases in those 18 to 40 are actually declining now. I show on the right, you can see here that it's even more dramatic in New York. You can see the targets, and you can see that the observed rate in New York on 2023 was 3.6 per 100,000. So making progress here. And again, hepatitis C elimination metrics, as we eliminated disorder, I'm just using New York State here data here, but you can see here that you have to have metrics for diagnosis, treatment, as well as the number of new infections to gauge the efficacy of your intervention measures. In the U.S., we had quite a challenge with access. It's improving. It's a challenge in the U.S. It's a challenge worldwide, but barriers are falling. Unfortunately, there are probably more barriers in the U.S., but essentially we need to be able to make hepatitis C drugs available to all individuals, and also not restrict prescriptions to those who are specialists, but rather have primary care providers also intervene and treat these individuals. These efforts can lead to a universal care pathway. There can be we need a rapid diagnostic testing. We have that available. We need to confirm active infection, preferably by point of care testing. Worldwide, DAA therapies are very inexpensive. Sofosbuvir, decladovir is extremely inexpensive. The most expensive part of treatment of hepatitis C probably turns out to be the point of care testing, documenting viremia. We have ways to assess fibrosis, and really for hepatitis C, cirrhosis or no cirrhosis. In the US, we use elastography, but you can use simple measures as well. Treating with pangenotypic therapy leads to SVR rate, again, greater than 95% of cases, and you can dismiss from care. So to summarize here, the take-home points, in the US, our rates remain low. Worldwide, diagnosis still remains the greatest gap, but this is improving now. Point of care testing is now available, and we need to leverage this. After diagnosis, we need to make sure that we deploy test and treat strategies. Do not have them come back. Try and initiate therapy when you meet these individuals. You need to access to providers needs to be decentralized with simplified models of treatment. Again, syndemic approach with decentralization. The access to therapy still is a challenge even in the US. We have some cost restrictions, though they are improving. Worldwide, again, soft decladovir and other DAA therapies the prices are really inexpensive. We need to address substance use disorder. We will not eliminate this until we deploy with hepatitis C elimination efforts, harm reduction measures as well. You still need a fibrosis assessment at the initial evaluation. If you have cirrhosis after SVR, you need to screen those individuals for hepatocellular carcinoma. And in persons who inject drugs, periodically screen these individuals at risk for recurrent infection. Remember that some people will reinfect themselves, but retreatment options are robust. And hopefully this is a disorder that we're going to be able to eliminate, again, without an available effective vaccine. I believe I am done. I will stop here and unshare. And I would be happy now and look forward to a discussion. Thanks so much, Sanjaya.
Yeah, thank you. Thank you, Paul. That was truly wonderful and so much of information in a short time, in 1 hour. I think it's a masterly job that you have done. You touched on a lot of areas like treating acute hepatitis C, treating hepatitis C and hepatocellular carcinoma patients. There are many areas post-transplants. It spans all across. So with that, let us get some questions from our audience. May I invite Dr. Prasoon Jalal from Baylor? And also, by the way, today our audience spans across the globe, and I see in the chat box, people are coming from Sudan, from Turkey, from Nepal, from India, from all over the world. So thank you very much for everyone who are able to find some time to join today. Thank you for joining. Prasoon, Jalal.
Thank you. Again, truly masterly talk, as Dr. Ko does all the time. And it's wonderful that Adherence is growing worldwide. Thank you. So, Paul, my question is more related to probably in our setting, in your setting, related to transplant. This week on call, I got 2 consults for a patient who, one got lung transplant, one got heart transplant, and of course for the kidney. How soon you start the treatment? What's your strategy at your place in post-transplant patients?
Yeah, I didn't talk about this, but now I'm going to. Let's talk about this. So let's talk about transplant and the use of HCV, NAT, nucleic acid positive donors, HCV RNA positive donors. So here is how we approach this, and we have systematically addressed this in the following way. If you have a hepatitis C positive donor that we know is NAT positive, we will start the pan-genotypic therapy just as soon as they're stabilized, Prasoon. And what we have done, and I actually went to the state of California, the state government, because about half of our transplants have state or public insurance. And we were able to get them to agree that we can start therapy immediately. So we have something called a TAR, treatment authorization, and they will authorize treatment immediately. One of our biggest challenges in using HCV positive donors was getting reimbursement right away. The state of California actually agreed, and it is in their policy now. And one of our fellows presented this data at the AASLD a couple of years ago. We don't need authorization anymore. It's automatic. And so we can just write for the DAA therapy, and it's automatically approved. And so we treat NAT positive. Those that are hepatitis C antibody positive donors, but NAT negative, those individuals we monitor, the majority of them won't develop infection, but we try and start within the first few days of stabilization. And these individuals do very, very well. Other centers I know actually even give a preemptive dose. You can do that with other organs. We have not evolved to giving the dose on the way to the operating room, though I know other institutions that certainly do this. We have kept our durations conservative for now. You know, there have been many studies that show you can treat just for 10 days or 2 weeks, right, for a kidney transplant. Right. We have erred on the side just because of these rare cases of severe hepatitis C recurrence that have occurred. We've erred for now on the side of keeping the durations at their standard durations for now of 12 weeks, although I will be the first person to acknowledge that that is likely an overtreatment. We actually went to other payers after we got the state of California, and I can, if anyone wants, I can share with you the legislation that they changed the law. But we actually then went to Blue Cross Blue Shield and the various other payers to see if they would be willing to do this, and we were not as effective. We were not as well received as we were with the state of California.
That's a great answer, because this is the same thing. We don't do perioperatively or preemptively. We do immediately after, but the difficulty I'm facing is that, of course, as you know, the recurrence for NAT positive donors in a recipient is 100% most of the time. So we try to initiate in the hospital, but it's getting a lot of resistance from the hospital side. The community, once they get discharged, it's not difficult, but still our delay is between 2 to 4 weeks. I don't know, Sanjaya, what you are doing in New York, but that creates some concern to our pulmonologist and cardiologist, including kidney guys, and they're worried about delay in treating. And the hospital system is not willing to purchase or get the medication while the patient is in the hospital, even if the patient is, discharge is delayed for one reason or other.
You know, I'll tell you, Prasoon, in New York, in our Northwell, we don't start the therapy while in the hospital. They within the 2 to 4 weeks, once they get out of the hospital, we always make an attempt to start in the hospital, but it does not binding. Once they
That's the
get out of the
same.
hospital, we start it. But they all get it. 100% of these patients are being treated, and we also keep our duration conservative to 12 weeks.
Great. Thank you.
Dr. Mukul Rastogi from India.
Thank you, Sanjay. Thank you, Professor Paul, for such a elegant talk. And my question to you, that's how to treat hepatitis C in those who are less than 12 years of age and those who are pregnant females.
Yes, let's go through each one of these. So let's first talk about those less than 12 years of age. We have now approved therapies now down to the age of 2 years of age. And you can use the same DAA therapies. We use primarily sofosbuvir-based therapies, but you can use either one. And then we actually also published a paper. We actually treated somebody, a baby who needed a liver transplant, whose mother had Hep C. They were 6 months old, and we used sofosbuvir, or we used sofosbuvir decladisvir. And so you can treat these individuals down to whatever age. Excuse me, actually she was 2 years old. Excuse me, she wasn't that young. But we were able to get decladisvir. We actually worked with BMS many years ago to get the therapy. And so sofosbuvir-based therapies are easy to administer, and that's for those who are under the age of 12. And again, we should treat these individuals. The drugs are very, very safe. Pregnant, sofosbuvir-based therapies for pregnant women, there's data. I shared the paper that was published in Lancet GI, and they have an ongoing study. It is a hard study to enroll in, just for the record. And the reason for this is obviously women, many women don't want to be exposed to DAA therapies, but these are very safe therapies. Theoretically, the pregnancy risk to be minimal, and at least in the U.S., women, when they are pregnant, especially those who have come from less than stable backgrounds, maybe their pregnancy may be one of the few times where they're engaged in healthcare, and it's your opportunity to affect a sustained response. And so, again, not recommended yet, but there are trials, and hopefully there will be data generated so that we will be able to get approval for these therapies to be prescribed during pregnancy. Otherwise, if they're diagnosed during pregnancy, what we have been doing historically is that we try and follow these individuals, and immediately post-delivery, we treat these individuals.
So, nice. So which is the best trimester for treating in pregnancy? Second trimester or first?
So we generally we have tried, just because organogenesis is in the first trimester. That's the trimester we try to avoid, and so second or third trimester. I've never treated, just for the record, pregnant women. Just for the record, we had a couple that we actually tried to refer to one of the ongoing national trials, but it didn't work out. I've actually not done that, but I would envision that, second and third trimester, there's no organogenesis at that point. Having said that, though, these drugs are safe. And when they were treated with ledipasvir, sofosbuvir, there were no adverse outcomes, regardless of when treated to the fetus.
Thank you.
Thank you, Dr. Rastogi. Now, Dr. Najia Kazi from New York City.
So, actually, I just want jumping into this debate. Pregnancy is finite. It's like 9 months and you're done. Where's the urgency of treating patients during pregnancy? Is that something that should be?
No, you raise an excellent point. I would just tell you that oftentimes pregnancy is one of the few times where they're engaged in the healthcare system. So it's your opportunity. We have had challenges where we have encountered women who are pregnant, deliver, and they don't return. they don't return for hepatitis C treatment. And you feel, in fact, I have somebody right now who is pregnant again with hepatitis C and cirrhosis that I saw many, many years ago. And when we saw her in the hospital, we said, come back, we'll treat you. She never did. She now shows up again. She's pregnant again, except now her platelet count, which was 200 when we saw her, is now 110. And she's got a big spleen. And so it's not an emergency, but if we can establish that it is safe to administer these therapies, I think getting these individuals treated, I think this is a further opportunity to reduce morbidity.
Sure, that makes sense. But one would argue that a person who doesn't turn up after pregnancy is not going to be compliant with the medication. But I see your point. Thank you.
Yeah. Oh, yeah. That point is well taken, by the way. I don't disagree with what you just said.
Thank you, Najia. We have a few questions in the chat box. Let me start with the first one from Dr. Sitaram Chaudhary. Dr. Chaudhary has been asking how many hepatitis C patients remain undiagnosed globally. Is that,
Yeah.
Dr. Chaudhary, that's your question, or anything else you want to add on?
Yeah. Sir, my concern is that huge number of patients are not diagnosed. We have got the treatment, but patients, they come like, at the end stage and close to death. And that time you come to know that the end stage is because of hepatitis. So what is the global scenario? Which country we are not able to diagnose much? What is the status overall?
So it is resource-constrained countries. Probably globally, my guess it's about half of individuals, or at least half, are not diagnosed yet. It may be higher, but at least half remain undiagnosed. So that's 25 million people, which is that's a substantial burden of individuals that we have not yet diagnosed with hepatitis C. And so we have the antibody now, and the important thing is we have good point of care antibody testing that doesn't document active viremia, and that this is a challenge that I was trying to make earlier in the talk, which is that 5 years ago, 7 years ago, many people were saying we just get an anti-HCV positive antibody, and hey, if it's positive, then if you don't have a lot of treatment in that area, you can just treat, and you may treat 15% of people who don't have the virus, but if it's a harmless therapy, who cares? Nowadays the viremia levels are low, and I don't know of anyone who actually did do this, but it seemed to me that wasn't an unreasonable strategy in resource-constrained areas. I don't recall seeing any papers published on that, but now we do need to document viremia, but that is the cost, Dr. Chaudhary, that we need to get down. I was sort of hoping that PCR costs, because of the COVID pandemic, technologies would improve. Do you know what I'm saying? And we would get the costs down for the reagents for point of care testing. But that, the PCR testing or viremia documentation is likely more expensive than are the DAAs, which you can get for, it's very inexpensive nowadays, thanks to our low-cost generics.
Thank you, sir. Thank you, sir.
Dr. Chaudhary, which country are you representing from and which city?
Nepal, sir, Nepal.
Okay,
Nepal.
Welcome. Thank you very much for asking that question. Najia, once again.
Hi.
So, Dr. Kuo, I know California has many American Indian tribal reservations. I don't know what they're like, where they are geographically around Stanford, but has Stanford or your group or other groups made attempts to have an outreach with them or have some sort of a collaboration with the Indian Health Services, etc.? Because I know HCV is overrepresented in the American Indian, Native American community.
Absolutely. So the answer is we did. And in fact, we had a telehealth program you may have heard of called ECHO. And we deployed that. One of our challenges was that these individuals got overwhelmed during the COVID pandemic. And it was much harder to engage in hepatitis C because they were overwhelmed. And candidly, and this is probably our shortcoming, we haven't gone back, but there are statewide efforts in the reservations, and actually the California prison system has a systemic approach to finding all the individuals with hepatitis C and treating them. So these are ongoing efforts, and these are not. These are not unique to California.
Thank you.
True. I mean, people are shocked when they know that there's like reservations in Long Island, in like the eastern tip of Long Island, but they typically tend to be like there's an inability to engage. I'm not saying that we're not engaging, or there's some, So I understand your point in terms of attempts at outreach, but again, I think engagement requires a lot of resources and someone who is committed and goes back after no's, etc. But thank you.
Suffice it to say, we have to do better.
Absolutely, I agree. Absolutely, that's why I brought up the point. Thank you.
I will go to Dr. Abul Hayat Manik, who asked this next question in the chat box for a while, and then I'll come back to Dr. Rishi Samal. Dr. Abul Hayat Manik, please introduce yourself as well, and welcome to Nexus. Dr. Manik?
Yes, I'm Abul Hayat Manik from Bangladesh as an hepatologist. I have a question, sir, that if a patient having hemodialysis and the patient was initially HCV positive, then he treated with a pan-genotype drug like valparasvir and sabasvir. Later, we are not doing the SBR 12, then we get SBR 24, that was undetected HCV. Then after 6 to 8 months later, again patient infected with HCV and RNA was very high. Then should we treat the patient again with the same pan-genotypic drug? Genotype was treated both times.
So does this person have ongoing risk factors for active infection? Do you think this was a late relapse? And do you have the ability to get genotype there?
That is pan-genotypic 3, and patient was having hemodialysis twice weekly. So that is the risk factor recurrence of the HCV infection.
Oh, and was it genotype 3 both times?
Yeah, genotype 3 both times.
And so, yeah. So you treated for 12 or 24 weeks?
24 weeks. Oh, no, first time we treated with the 12 weeks. Valparasvir and sabasvir only.
Decladisvir and sofosbuvir, right?
Yes.
Do you have, okay, so you have a choice. So you could either treat again for 24 weeks, okay? That might be the best. Do you still have this older drug called ribavirin? Do you have access to ribavirin?
No.
No.
We have valparasvir and ribavirin is available here only.
You do not have ribavirin?
No.
No, okay. It's a nucleoside analog. We used to use it. Prasoon and Sanjaya remember these days, but
No.
this was.
I think Dr. Manik is saying ribavirin is available, right? You said?
Ribavirin is available. Whether we should add the ribavirin in case of hemodialysis patient.
Yeah, so you can. Oh, thank you, Sanjaya. So, I would probably treat first. How anemic are they? Are their hemoglobins okay? In other words, it's not like 6 or 7, is it?
Hemoglobin was around 9-10.
9-10. So I would treat with 24 weeks of sofosbuvir decladisvir first to see if you can get an SVR. Hard to know if it's a recurrence or a new infection. I would try that first. I suspect it's hard to get resistance testing, right?
No, we don't have the option.
Yeah, you don't know. It's hard. Yeah. So I would try and treat with 24 weeks. If that doesn't work, then the other thing you can do is you can add a very low dose of ribavirin. Very low dose, like 200 milligrams 3 times a week. But you have to have the ability to look at the CBC because it's so hard to predict whose hemoglobin goes down. So some people actually tolerate the ribavirin reasonably well, but others, and I have seen some just dramatic drops in hemoglobin as well. And I've never been able to figure out, and in your part of the world, you probably have thalassemia as well, right? Do you have thalassemia there? You just have to be careful, I'm saying, as far as the hemoglobin. But what we have done successfully previously was, before we had our salvage therapy, soft bell box, is we just add a touch of ribavirin, and that seems to help the SVR, but I would actually first go with 24 weeks of soft DAC.
Okay. Thank you, sir.
Thank you, Dr. Manik. And Dr. Rishi Samant from North Carolina.
No, sorry, Sanjay, thanks. This is Rishi Samant. I work with Oshner. Paul, great talk. I do practice in Louisiana, and my nurse practitioner still runs the clinic which Dr. Bill Cassidy had for 20 years.
How wonderful.
So we have the subscription model. I was a part of it. I'm still part of it, as you're aware. We started that a few years back. We paid a subscription to pharmaceutical companies to get those unlimited access to Hep C medication. We saw like there are 40,000 individuals in Louisiana who may have Hep C, and the target was 10,000 per year. As you rightly said, after COVID was a big hit for us. We were not able to do all these things. Numbers slowed down. But still, the numbers are slowing, and our targets, I'm not sure whether we are going to meet our targets despite having this subscription model. And we thought when I talked to these IV drug abusers about getting these Hep C medication, which are covered by Medicaid, the struggle I saw, like few of these IV drug abusers say that they don't want to come because they're worried about criminal charges in contact with healthcare agencies. And I think this is also a big thing that we are not able to get patients coming into the system. Any thoughts you think on this? Like, how can we address that? This is a bigger problem. There is a collaboration of government agencies, everyone, but the patient doesn't want to come because of these laws around the drug abuse.
Yeah, Rishi, that is, first of all, congratulations. I think Louisiana has deployed a program that I think in the US, we can all learn from more effectively than virtually any other state. My own opinion is that this is going to require education, and that we have to try to destigmatize addiction. Okay, you're not criminal, you have a disease. Just like people have diabetes, just like people have hypertension, some people have addiction, and you acquire an infectious disease, right? Just if you have a sexually transmitted disease, we don't usually arrest people, right? And so I personally think, though, that we will need to educate our legislators so that they can decriminalize this disorder of addiction and get people and link people to the help they need. I am hoping that our current HHS leader, who has some experience with this, would understand the need to decriminalize this, because addiction is something that permeates the entire world. It doesn't matter what socioeconomic strata you're from. It's just that I think some people have more resources to contend with this than others, and that's my opinion on this. These people have an illness just like others that we treat, and you should not be penalized for that.
Okay. Thanks for the talk, and thanks for accepting our invitation for ECG course next year. Okay. Thank you.
Thank you, Dr. Samant. Now moving on to Dr. Kemal Kalista. Kemal Kalista, are you still here? Would you like to ask the question? Yes.
Yeah. Thank you. Hi everyone. I'm Kemal from Indonesia. I'm a hepatologist. So many patients with HCV also has CKD on hemodialysis, and let's say we have achieved the SVR after completing DAA. Any recommendation? How long do we have to repeat the HCV RNA after we achieve the SVR? Thank you.
Oh, thank you very much for your question. So the question is, what is the durability of sustained response in somebody who has hepatitis C, who is treated, who is on hemodialysis? And the answer is the durability is the same as if you were not on hemodialysis. So once you've achieved SVR, then as far as durability, then you don't need any further testing. However, just like on the previous dialysis case, the trouble is that depending on where you are in the world, it may be more challenging to prevent exposures to hepatitis C in various dialysis units. And so for that reason, it may be that you need periodic surveillance for your hepatitis C, not for the efficacy part. The DAAs work, but it is just because of ongoing potential risk cross-contamination, which, for years in dialysis units, this was a bit of a challenge. In the US, it's largely now mitigated, but healthcare exposures, every now and then, they come up. We have seen little pockets of dental practitioners, of endoscopy units where hepatitis C was transmitted. So in that sense, it may be appropriate to periodically survey. I think, and the policies there usually depend on different dialysis units. But the durability of DAA therapy is actually very robust. Otherwise, it's accidental re-exposures that you would need to be able to account for.
Thank you. Thank you.
Thank you, Dr. Kalista, for joining. Paul, may I ask you a couple of questions? One question that I would like to ask is, if a patient, I always come into this dilemma of whether to treat or not, especially if there are transplant candidates. Let's say a patient has a hepatocellular carcinoma, and the patient has an active hepatitis, chronic hepatitis C, because nowadays we can send all these patients to get hepatitis C organs, and there is always at least in the United States, that option is always available. Do you think is it worthwhile really treating? You mentioned that there is a good chance of getting them cured, and you may have survival benefit. If they're transplant candidates, would you treat?
So the answer is we use a lot of NAT positive organs. And so we tend not to treat these individuals. Okay, we tend not to. Let me tell you where I do treat, Sanjaya. So I will treat if the patient is outside. In the US, we have something called the Milan criteria, where we have to downsize. And so if we are downsizing, in the US, we have something called all comers, which basically means someone comes in with hepatoma outside the criteria for transplant, but with our various local regional therapies, we can downsize the tumors. If they have hepatitis C and have an extensive HCC burden, because of the data that Amit Singhal shared showing that there's a survival advantage, I actually treat those people up front. And just because, do I know that I'm doing anything to reduce the HCC progression? I'm not sure, but when I saw the survival advantage, I said, okay, I want to do everything I can, because these individuals, we are trying to get them to the point where they will have a window where it's safe to transplant these individuals. And I treat those individuals only. If you have a 2.5 centimeter left lobe HCC that you treat with TACE, those people we do not treat, and we just accept HCV NAT positive organs. And our wait times, and I suspect in New York maybe it's also the same, your wait times have declined substantially over the past few years. And so no longer are we waiting 2, 3, 4 years for transplant. And so I'm quite comfortable just waiting for the vast majority, but big burden of HCC I treat.
Yeah, plus also we can actually reduce their risk of decompensation and maybe allowing them to treat those cancers better, actually.
Yes, well taken point. Yes.
Yeah. Dr. Nadia Kazi in a role again.
No, it's just like, because this is such a social issue, and these causes are close to my heart. It's just that in terms of Dr. Saman's point that the patients, I guess, in New Orleans are, because drug possession is a felony, so their concern in plugging themselves to the clinic is that, they may get followed or by law enforcement and end up being charged, etc. because of the ongoing drug uses. So my suggestion is maybe you could have Dr. Cassidy sponsor a bill that these patients should have some sort of an amnesty for the duration that they're on treatment. After all, the duration of treatment is, 8 weeks now, 8 weeks, 3 months. So it's a thought, it's a creative thought, but so that just to get more patients into treatment.
Sure.
Yeah.
Yeah, no, I agree. But again, I would hope that Dr. Cassidy would also educate legislators in that, addiction is a disease. Okay, this is not a crime.
Right.
These are people who need help.
Right.
And hopefully the current head of HHS would be able to lead a national effort just based on their own experiences to increase awareness of addiction.
Absolutely. This, if there's a time, this is the time. With Mr. RFK having had, in the past, kind of suffered from this. So if there's a time, this is the time to get that amnesty letter for the duration of treatment and then treat all these patients.
Yeah, agree completely.
All right. So, any other questions from the audience? We'll give a couple of seconds here. If we see any other questions from anyone else. If not, I think we are coming to the end of our meeting. Thank you, everyone, for joining today, and spread the word. And please keep joining. We're doing this every 2 weeks, and I think this is one of the unique forum where we have a state-of-the-art lecture from one of the best from the world, from around the world, and you are all joining from all around the world as well, and making this conference so lively and engaging. So thank you again for joining. Please keep joining. Dr. Cole, thank you so much.
Thanks for the kind invitation. Enjoy your day. Thank you.
Thank you. Thank you,
Bye-bye.
everyone. Bye-bye.